All right, so let's get started. We're talking about fun stuff, or actually the stuff that happens after the fun stuff. HIV and STDs. Thank you. I've been working 5-6 years. I've been working on these jokes, so they only get better. Fine wine. Okay, so getting HIV, we know this is a human immunodeficiency virus. What's the problem with this virus? It's a retrovirus. What does retrovirus mean? It liked viruses before it was cool, or yeah, it incorporates itself back into the host DNA, right? So that way you functionally turn into an HIV factory. Okay, why is that a problem? Okay, for treatment, it can be very difficult to treat, but what's the I component there of HIV? Immunodeficiency. So obviously, what does it do to our immune system? It makes it deficient, right? Which means what's going to happen to those patients? They're going to get infections, right? So again, that's the thing, is like it's not necessarily that the virus is just sitting there reproducing. It's the fact that it's devastating your immune system over time, and that's why when we're looking at the monitoring parameters for this, what's the big thing? What's the big cell you're looking at? CD4 cell count, right? So again, because it's primarily infecting those cells and getting rid of them. One time I had a patient in the ICU, as a student, as my preceptor there, and the patient's CD4 count was 2. And the guy was like, where are they at? Like, in his big toe? Like, what? There's only 2 of them, right? So they can get, this can completely wipe out the patient's immune system, right? And so that's when you start to worry about different types of infections, like pneumonias. Like, what kind of pneumonias, though? Yeah, so like PJP, so pneumocystis jirovecii, right? So that can happen. Do normal, healthy individuals get PJP? Nope. How about TB? Do healthy individuals usually get TB? Nope. How about Mycobacterium avium? There's a host of things they're going to get: fungal infections, viral infections, bacterial infections that healthy individuals don't get. So this is the problem, right? So the big thing we're focusing on here is trying to maintain their immune system for as long as possible. That's what the big thing we're focusing with the medications we're going to be supplying for these patients here. And again, this is depleting the immune system, and so it's not that the AIDS necessarily is going to kill these patients, the HIV is going to kill them. It's the secondary infections, right? These opportunistic infections. In healthy individuals, they don't have an opportunity to infect us, but if you do have HIV and you wipe out that immune system. And again, who do these people kind of look like as far as from an immunodeficiency standpoint? Who are we giving this sort of immunodeficiency to as providers? Transplant patients are a good example, right? Because again, we have to make sure their immune system doesn't fight the transplanted organ, right? Who else? Maybe not burn patients. Think about patients with cancer, right? We're giving them chemotherapy to try to wipe out. That's one of the myelosuppression. So that's one of the main dose-limiting side effects of chemotherapy is you're wiping out their immune system. So functionally, they have the same immune system as someone with really kind of late-stage HIV, right? So again, this is the big problem here. This is why we're going to be focusing on trying to help maintain their immune system as long as we can. And this is where we're going to get into our treatment with highly active antiretroviral therapy, which is HAART, right? So HAART therapy is going to be the mainstay of therapy, right? So pharmacotherapy is big deal. So looking at this, we're going to look at the life cycle of the HIV virus, right? So again, we're starting off with the virus here. What you're going to find is it has to make contact with one of our immune cells. It's going to have to actually cause this fusion to occur, where it's going to be fusing with our cell, right? That's how it gains entry into one of our healthy immune cells, right? At that point, the reverse transcriptase is going to be working to do what? Inject its code into our DNA, right? So this is where that retrovirus, that reverse transcriptase is going to work to incorporate its DNA, and this is where you have this integration that occurs here. After that, we're going to find that our DNA is now starting to reproduce the virus for itself. We get all the little components, and you're going to find that there's an assembly that occurs here. And again, you're going to find there's several different components here. Actually forming the DNA itself of the virus, actually cutting up the bits of protein that we're making to form the functional virus, and at that point it can bud off and then go off to do what? Infect more cells, right, to go and cause more factors to be produced, right? So again, this is a very repetitive cycle here, and this is where we're going to try to interrupt it as several different steps along the way, as we're going to see here, okay? And you can, again, see that different drugs are going to be working at different steps in the process to try to interrupt this and prevent it, right? And so again, could I just give one drug and treat patients HIV? Unfortunately, we can't, right? You usually have to use a cocktail of different drugs, at least 3 drugs at a time, to try to make sure you're attacking different components of the cell cycle or the replication cycle to try to prevent further virus from being produced. And so we mentioned CD4 count is a big thing you're going to be monitoring for. when it comes to monitoring for the immune system function, what's the other thing you normally monitor for? Talk about a viral load. Anyone ever heard of that? So that's what we're looking for. So the viral load tells us what? How much the virus is actually replicating, right? And ideally, we'd like to get down to what sort of number? 0 would be fantastic, right? So if we can have no detectable viral RNA, that would be fantastic. That means the virus is replicating at a slow enough pace we can even detect it in the bloodstream. That's fantastic. So we want their viral count to be low, and we want their CD4 count to be high, because that means we have a good, competent immune system. Okay, so these are the things we're shooting for here. Okay, so again, you have to know the targets for the drug therapy, and to know that, you have to know what the life cycle is of the virus itself. And so basically, the virus is going to be entering the body. It has a glycoprotein that has that affinity for the CD4 receptor. So by finding those white cells that have the CD4 receptor, that's where it's going to preferentially be binding to. And so you're going to find that there's other receptors that help this binding to occur. Namely, there's one here called CCR5. That is going to be important for causing the virus to kind of latch onto those cells so that it needs to fuse with that cell to get in. We'll talk about a drug that affects CCR5 specifically. And once it's bound, then you're going to cause membrane fusion to occur. By causing this fusion to occur, that's when the viral RNA can then get into the cell itself. And so we're going to find that this is another drug target. By preventing the fusion from happening, prevent the virus from ever getting into the cell. Okay. Next, we're going to find that it uncoats. It's going to have this single-stranded RNA. And by using reverse transcriptase, that's where it's going to be incorporating itself into our DNA. Okay. Now, HIV itself, the virus, is it a very efficient worker? Pretty efficient, but is it interested in high quality work? Not necessarily. It's pretty sloppy, right? So because of that, there's a lot of mutations that occur. Why is that a problem? Because we're shooting for a moving target, right? So again, our drugs you're going to find over time tend to maybe develop resistance. The virus will develop resistance because the actual DNA of the virus itself, or the RNA, is changing, right? It's constantly changing. And so that means that we may have a drug that's really effective at one point, but then as it mutates, that drug can be completely ineffective. In fact, you can lose whole classes of drugs depending on a single mutation that occurs here. So this is where things like genotyping and phenotyping are going to be very important, because you need to know what kind of virus you're dealing with to know what sort of drugs are going to be maintaining their efficacy. Okay, so that's another key component we're going to be looking at a little bit later. So the HIV reverse transcriptase and then forms a double-stranded DNA that gets incorporated into our DNA there. So this integration has to happen by this enzyme integrase. Again, we're going to find this is another target for drugs. So kind of make a key of that, or make a note of that. And then now the host cell is now starting to produce the viral RNA and proteins. At that point, once the proteins are being produced, we're going to have what we have an enzyme called protease. Protease does what, do you think? Kind of chops up the big long strand of protein that we produce from that viral DNA, and then it's going to make basically the functional virus. So if we can hopefully prevent that from occurring, we're going to find that's another drug target. Hopefully we can prevent from forming new functional HIV in that case. And at this point, it's just a wash, rinse, and repeat. It's going to then butt off out of the cell to go infect another cell, and then kind of starts all over again. Okay. So you've already seen there's a lot of different targets here for our different drugs to be working, and so by using different combinations of drugs together, you get that synergy, which is going to be really useful here. Okay. So anyway, so kind of three main stages of the infection. So there's going to be an acute retroviral syndrome, and it's kind of this mononucleosis kind of like illness that occurs here initially, and then it goes into this kind of latent period where the patient definitely has the virus is replicating, but they have no overt signs and symptoms. Immune function is still pretty good for the most part, and this is where they develop this kind of this chronic infection here, maybe some time before you actually ever notice it. In some cases, it may not be until you get what they call an AIDS-defining illness. What could be an AIDS-defining illness? PJP is a good one. Mycobacterium avium complex is another one. Cancer, Kaposi's sarcoma could be known. There's a whole host of them that are out there. Once you have one of these illnesses, that shows that you have a sufficient amount of immunodeficiency to be considered to have the acquired immunodeficiency syndrome, right? So you have AIDS at that point. So this is what we call AIDS-defining illnesses there. So anyway, so the main monitoring we're shooting for, though, is one, the CD4 cell count, because that tells us how competent the immune system is. And we're looking at the viral load to see how active the virus is actually replicating. So CD4 count should be high, viral load should be 0, it should be undetectable, ideally. So our goals when managing this is try to decrease the morbidity and mortality. Nowadays, what do you think is more prevalent, the mortality of these patients or the morbidity? Morbidity, right? Because again, HIV is now a chronic disease. Now, if we'd said, say, back in the 1980s, late 80s, what do you think would be more the issue? mortality. We really didn't have any drugs in order to treat this. So, and again, a lot of these patients were not being treated or being caught very early. And if you remember looking back at the EpiBio stuff, remember looking at those graphs there, we saw patients who were diagnosed very early on in the AIDS epidemic. You found that most of them were not alive by the time 1990s rolled around, right? Nowadays, though, this is a chronic illness. Now we're dealing more with the morbidities that show up secondary to management with these drugs or management of the virus itself. So we're going to focus on that, increasing quality of life, hopefully preserving the immune system. It's a big deal. And then hopefully preventing transmission, right? So preventing from being spread from person to person is going to be ideal. And so this is going to be accomplished by basically by trying to have a durable and maximal suppression of the HIV replication, which means that our viral load should be 0, should not be able to detect it in the blood. By doing that, that shows us, yes, we have suppressed that virus maximally. That means it's a low risk for transmission to someone else. That means it's low risk for causing more kind of sustained damage to the immune system over the long term. Okay, so this is the big thing we're shooting for. So the general approach is that one, we're going to be looking at, again, I mentioned the viral RNA levels tell us how kind of proactive the virus is being, how active is it being in replicating itself. The CD4 count tells us the extent of that damage. By using the HART therapy, the highly active antiretroviral therapy, the idea is we're going to have undetectable RNA levels while trying to maintain that CD4 count as high as we can there. And so what we're going to do is use a combination of antiretrovirals. So at least 3+ agents here, right? So you're already on 3 different drugs to manage this right off the bat here, okay? And so we have to be careful because one of the things we're going to find is that with resistance starting to develop, you're going to end up losing different options that you can actually treat that virus with. So if you have someone, say for instance, you know, if you have an acute otitis media and you stop taking your antibiotics early, what can happen? You get more resistant bacteria the next time. Well, imagine if you had someone who's non-compliant with their HIV meds, what's going to happen? Well, they're going to get a more resistant sort of HIV virus, and that's going to be more difficult to treat in the long run. And so you're going to find that then when they spread that to someone else, guess what? Now that person maybe potentially has a more resistant sort of strain of the virus that's going to be more difficult to treat, right? So this is why the big thing I cannot stress enough, because again, this is something you could just focus on and just focus on HIV for the rest of your career. There's pharmacists who do just this. If you talk to one of them, they can give you way more information than I ever could, because again, I don't deal with it every single day. However, look stuff up. You're going to find new drugs are coming out with some regularity, which is nice. In fact, my lecture had to be updated just with a new kind of new primary recommendation. And always look up the new regimens that are being recommended here, right? So again, if you go to the NIH website, the AIDSinfo.gov, I believe it is, I have the link in a couple slides from now. Go to that and see what the new regimens are. See what the new recommendations are going to be, because they change from year to year. And they'll say this is the #1 recommended regimen. You may find 5 years from then it's something completely different. Whole new classes or different classes are going to be what's recommended based on resistance patterns as time goes forward. Okay. So anyway, so when do we start treatment? This used to be a little bit more of a moving target. We used to say, well, we're going to wait to start treatment. We know we have the virus. We're going to wait till your CD4 count gets down to a certain threshold. Maybe we'll wait till it gets down to 400. Maybe it gets down to, say, 300 or 250. What they actually found is with the studies that the earliest you can start treatment, the better it is for the patient. The more likely you're to have a sustained, healthy immune system for the longest period of time. So as soon as someone gets diagnosed, they need to start antiretroviral therapy that day, okay, or as soon as possible. So that's going to be recommended from that standpoint, especially since it can reduce transmission. And hopefully you're going to have fewer AIDS-defining illnesses that can develop in that patient, right? Hopefully maintain their immune system for as long as possible. And keep in mind, you know, this has only been around since the 80s, right? So it's only been 30-some odd years we've been dealing with this. We've been dealing with diabetes and hypertension for much longer than that. So this is still a relatively new sort of field here, and that's why the changes and recommendations are happening all the time. So anyway, here's the main classes of drugs you're going to be dealing with. We're going to have our integrase inhibitors, which are hopefully going to prevent the viral RNA from integrating into our DNA. We're going to have our nucleoside or nucleotide reverse transcriptase inhibitors. These would be your NNRTIs. Next, you're going to have your non-nucleoside reverse transcriptase inhibitors. So again, both of these are going to have the activity of inhibiting reverse transcriptase, which is what incorporates that into our DNA, right? But they're going to have a little bit different activity. The mechanism is a little different between these two, as we're going to see in a second. Next, we have our protease inhibitors. And then we're going to have entry-fusion inhibitors and our co-receptor inhibitors. So these are the main classes we're going to run into. And I'll talk about the different adverse effects and all of that, your drug interactions, and this is going to be really important when we go forward, is to notice what the main interactions are, what the main kind of unique side effects are, etc. With these drugs. So getting into the NNRTIs, the nucleoside, nucleotide, reverse transcriptase inhibitors. Basically, these are going to be based off the purine, the pyrimidine, nucleotides, and nucleosides. So if you remember back to our chemotherapy lectures, do you remember the anti-metabolites? Remember something like Ara-C or cytarabine? It was actually something that looked a lot like cytidine, but it had changed the structure a little bit so that it would get incorporated into the cancer cell DNA, but then it couldn't elongate any further. You guys remember that at all? If you go back, I swear we talked about it, but you see you can't basically add on any more DNA, any more nucleotides to that strand anymore. And so eventually led to inhibition of DNA replication, eventually led to cellular death. Basically the same thing is going to be happening here. And this is another case where HIV specialists, they love their abbreviations. And so I list them here, but you don't need to know these necessarily for the test or anything like that. I'm not going to put the abbreviations on the test. I'll put the brand names on the generic names, but I just want to give you an idea. So when you're dealing with a patient with HIV, and you look at their chart, you may see stuff like this all over it, right? Oh, they're on AZT plus blah, 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 plus this regimen, right? And so just know, you just look that stuff up, right? So you know specifically what they're talking about. Because what's the problem with abbreviations? They're prone to errors, right? So again, if you were to get them mixed up or you misread one, you can get the wrong drug in your mind there. But you know, things like, you know, zidovudine is AZT. Like, well, that doesn't make any sense, right? Usually it's based off the chemical name of the drug, not necessarily the generic that we are kind of used to seeing there. And don't worry about whether it's a thymidine analog or a deoxyguanosine analog. Just know that they're working as an NRTI. They're going to be preventing further strand elongation by getting incorporated into that DNA. So here's a picture kind of showing you that basically what happens is that the drug itself gets phosphorylated to this triphosphate form, and it's going to be basically competing with endogenous nucleotides for these sites here, specifically reverse transcriptase. And you see this kind of big pink blob here is reverse transcriptase, right? Here you see the actual enzyme itself right here. And this is the new viral RNA that's kind of passing through. Here's the DNA. This is going to be produced by that reverse transcriptase that it will eventually get incorporated into our DNA, right? That's where the integrase enzyme is going to be coming into play here. Well, imagine if you were able to slap on a little kind of end cap right here. This is the drug. This is the zidovudine or any of the other ones we talked about. Basically, it's going to be slapped on the end of that, and we call that a chain terminator. And you cannot elongate that any further, which means you have an incomplete set of the viral DNA. It doesn't get incorporated into our DNA, and thus you don't have further replication of the virus. That makes sense? So it's a reverse transcriptase inhibitor, even though it doesn't actually affect the enzyme itself. It's basically just getting incorporated right there, and you can't add anything onto it. So if you want an example of that, go back and look at when we talked about our chemotherapeutic agents like cytarabine. That was another good example of something doing very, very similar activity there. So adverse effects are typically mediated through this mitochondrial RNA and DNA synthesis here. So you typically are going to see these more with stavudine, didanosine, and zidovudine. These are kind of the older agents in this category here. And a lot of the newer ones actually lack a lot of the side effects here. So some of the new ones like abacavir, tenofovir, emtricitabine, and lamivudine. In fact, a lot of the drug regimens you're going to see listed as first line nowadays include tenofovir, emtricitabine, or lamivudine. So that's why we're using these, because they're newer, lack a lot of the side effects of the older agents. So what are some of those side effects? We see things like peripheral neuropathies, so develop neuropathic pain secondary to using these drugs, pancreatitis, lactic acidosis, this fatty liver, so some hepatotoxicity seen there, lipoatrophies, a lot of side effects are seen with it. However, it gets mitigated with the newer agents, as I mentioned. One unique thing, it's kind of unique to abacavir, is you actually have to test for this polymorphism here. It's called HLA B5701. You test for that in patients before starting abacavir, and if they have that mutation, they're actually much more likely to have a hypersensitivity and anaphylaxis. So it's one of the rare cases where we actually do pharmacogenetic testing prior to starting a drug. Now again, abacavir is not listed as a first-line recommended drug because of this additional testing, but say for instance the virus became resistant to something like emtricitabine and tenofovir, you may want to check for testing with the patient to see if they might be a good candidate for something like abacavir. That make sense? Okay. The next class is going to be our non-nucleoside reverse transcriptase inhibitors. These are the NNRTIs. So that's already getting complicated. NRTIs versus NNRTIs. You can go back to the name. So this is a non-nucleoside. So you know it doesn't have anything to do with getting incorporated into the DNA itself. But basically what it's going to do, if you imagine here, the reverse transcriptase, basically is going to change the conformation here of it. And so it cannot read the viral RNA any further. So basically, by interrupting and kind of monkeying with the enzyme itself, you can't produce any new viral DNA. There's nothing to get incorporated with our DNA unless you do not have replication of the virus. So again, do you think you get synergy mixing an NNRTI plus an NRTI? Absolutely, you could definitely get synergy there. And in fact, that used to be one of the more recommended drug regimens. You would include an NNRTI plus an NRTI as a regimen. You get some synergy there, both of them working on different aspects of the reverse transcriptase, right? So ones we have in this category include delaverdine, we have efavirenz, nevirapine, etravirine, and rilpivirine. Again, it's going to take repetition to kind of look at these drugs and be able to link them back to their specific category. Okay, so again, I know there's a lot of drugs here, but repetition is going to be able to help you with this and being able to place these into individual categories. Overall, pretty well tolerated for the most part. Maybe some rash, some transaminitis. What does that mean when I say transaminitis? Are transaminases inflamed? It kind of doesn't make sense when you think about it, but basically it means your LFTs are going to be increasing, right? So it's going to cause some degree of hepatic injury. You see your AST, ALT increase, but again, transaminitis is one of those words that actually doesn't make sense if you think about it too hard, so just don't think about it too hard. Now, this is kind of interesting. In fact, the NNRTIs are starting to take a little bit of a back seat in heart therapy, mainly due to the fact that there's a single viral mutation that can actually confer resistance to the entire class except for etravirine. That means it's just one mutation, which could either happen spontaneously in the virus, or it could be if you're maybe non-adherent to therapy, that basically you end up losing, you could be on efavirenz and then you end up losing almost every single drug except for etravirine. Now, why is that problematic? That's that many drugs you can't use anymore. Once it's resistant, you can't use that drug anymore. That whole class could be wiped out almost except for etravirine. So again, that's bad, right? Just like when someone comes up and they say, oh, I have a penicillin allergy. Okay, well, what kind of reaction do you have? I don't know. My mom said I had it when I was a baby. It's not great because then, okay, well, I can't use penicillins anymore. Maybe I can't use cephalosporins. Maybe I can't, right? You don't want to deal with that, right? So again, you want to be able to keep as many classes available to you as you can, because as I mentioned, you know, it'd be one thing if these patients were only being treated for 5-10 years and they succumb to the disease, but nowadays they're living 20, 30, 40, 50 years, right? So again, they're living for much longer, and so we need to make sure we keep these as active as long as we can.
If they do get that mutation and they're still they're also using an RTI with it, with synergy, can that overcome the resistance or not?
No, in that case, we have enough other drugs that we could get additional synergy from that we would just avoid the class altogether. That's a good question. And we'll talk about kind of how we select our cocktail in just a few minutes here for sure. That's a good thought. Okay, next up we have our protease inhibitors. So this is another big class. This is another one of those kind of backbone of regimens here. So you see here that initially when you have the viral proteins being made, after it gets integrated with our DNA, it's going to be in sort of this non-active sort of form here, right? So it has to get kind of chopped up and put back together, so that way it becomes the actual active form of the virus, right? So if I were to leave it in this kind of uncut state here, where it's kind of in the inactive state, you're producing the protein, but it's not really doing anything. It doesn't actually produce any new active, active viral particles. So that means your viral load would do what? It would go down, right? Because again, nothing's actually exiting the cell. No active HIV virus is doing this. So this is the best thing, or one of the big classes we're going to use quite frequently, is by inhibiting the protease enzyme, you can't produce those mature proteins. You can't produce a new mature virus here. And so we have things like atazanavir, we have darunavir, fostemprynavir, indinavir, lopinavir. Now, this is notable because most of the time it's going to be in combination with a drug called ritonavir. We'll talk about that in a second. Now we have nalfinavir, ritonavir itself, sequinavir, and tapranavir. Now, again, it'd be nice if you could just look at the vir on the end of the drug and say, oh, I know it's for a virus. But the question is, like, what kind of virus is it for, right? So acyclovir is not used for HIV. It's used for HSV, right? So again, be specific here. Just because it's vir on the end, you can't just necessarily assume what its use is going to be there. You know, it's for a virus, but you got to figure out which one it's for, right? So adverse effects are kind of interesting here. You get certainly some GI distress, but you also see things like increased lipids. You see things like glucose intolerance. And so what we're actually finding is these patients are being treated for longer on these heart therapies, is they're developing all these metabolic conditions that would just be getting if they're getting older anyway. So hypertension, dyslipidemia, diabetes, heart disease, things like that. And so some of these can be exacerbated by the drugs we're actually using here. Kind of another kind of unique thing you get with the protease inhibitors is this lipodystrophy that usually manifests this buffalo hump, as they describe it. Basically, this altered fat distribution that occurs here. So kind of unique sort of side effect. Now, the kinetics here are really important for the protease inhibitors. Most of these are going to be metabolized in the liver. What's interesting here is that a lot of times we give one of these protease inhibitors along with one or two drugs, one called ritonavir, which we saw as a protease inhibitor, or a drug called cobicostat. So what these do are they're actually 3A4 inhibitors. You say, well, it's a 3A4 inhibitor, it shouldn't be good, we shouldn't be using that. Actually, we do want to use it for its pharmacokinetic boosting properties. So basically by using a 3A4 inhibitor, this helps us to drive up levels of the other protease inhibitors you may give it with. So for instance, there's a combination I saw on the last slide, it's a lopinavir plus ritonavir. It's called Kaletra, so it's a combination drug that comes with that. Basically, the ritonavir has minimal activity against the virus, but the lopinavir definitely does. And by boosting it with that ritonavir, the levels go up higher. And so what do you think it does for your drug dosing? What do you think it does about the frequency? Less frequently, right? So before, you'd have these patients with HIV, you'd be taking these cocktails, they'd be taking, 30 different pills, 4, 5, 6 times a day. Now, by using these boosted regimens, you can get away with a lot lower pill burden, is what we call it. So they're taking medications, fewer pills, less often, which is good. So that's using that boosted effects there from blocking the activity of 3A4. So either cobicostat or ritonavir have that 3A4 inhibiting sort of effect there. So you have higher doses, or we have higher drug levels, less frequent dosing. But however, that still means that they're interacting with all these other medications too. So if I was giving someone a protease inhibitor and they developed hyperlipidemia, what would you think to give them to treat the hyperlipidemia? Give them a statin. Well, if I give them simvastatin, what could be a problem? Simvastatin was a 3A4 substrate, and now I have these 3A4 inhibitors on board. I wouldn't want to do that because, right, I run the risk of hepatotoxicity, run the risk of rhabdomyolysis. What can I do instead? Rosuvastatin, or it's probably one of the big ones, but something like pitavastatin might be a good option there. Fluvastatin might be a decent option there, but rosuvastatin is one of the good ones, right? Lipitor give you the same interaction too. It'd be another problem sort of drug from a 3A4 standpoint. So again, keep in mind these interactions. Anytime you see someone who comes in with HIV, make sure you double check their medication list, because again, what they're coming in with could be a side effect from someone not recognizing there's a drug interaction based off of these sort of things, right? So keep that in mind. Up next, we have our fusion inhibitors. There's only one drug in this category. It's called Infuvirtide or Fusion. And so this is actually interesting because it only inhibits HIV-1 envelope infusion, right? So again, this is going to be where the actual virus is combining with our cell trying to gain entry into it, right? It's that fusion process there. This is actually interesting because, again, predominantly over here in the US, HIV-1 is quite predominant. However, if you went to somewhere else where HIV is more endemic, like Africa, you actually find HIV-2 tends to be a lot more prominent. So that means that something like this, Infuvirtide, actually have limited activity over there, unless you were checking to see which subtype of the virus actually had beforehand. But anyway, this is an amino acid peptide, which means peptides, so no oral administration. So this is actually an injectable product these patients are going to have to be given subcutaneously. And so again, you can see some injection site reactions from that. Some pains, merythema, nodules can actually form. So it's good to make sure you spread around the injection sites. They don't inject the same spot every single time, but maybe spread it around the abdomen or something like that. Next, we have our CCR5 Antagonist. So if you remember, we're talking about, yes, sir.
Is that fusion inhibitor a drug that can use to help prevent catching it?
Not necessarily. I've not seen it used specifically for that. They're trying to think if there's any cases for that. Typically, and I'll talk about post-exposure prophylaxis a little bit later on, but typically we're using oral meds for that with different mechanisms in that. I don't know if that's ever been tried. It might be a good question to check the literature for it, PubMed or something. But up next, we have our CCR5 antagonist. Remember, this is one of those co-receptors that the HIV is kind of looking for. And so certain of your cells may express this. And actually what you end up finding is that the drug itself is binding to the human receptor. Actually, it has nothing to do with the virus. However, you have to make sure you're actually checking the virus before you're giving this. Because after a while, what you're going to find is that the way the virus becomes resistant to this is they end up lacking that receptor that's binding to the CCR5. So by losing that and say, okay, we don't even care if that CCR5 is there or not, we're just going to be able to bind to the cell regardless by looking at that CD4 receptor. So it actually ends up loses efficacy over time because of that mutation there. And again, pretty well tolerated, some rash, hepatotoxicity, but what you're finding with a lot of the newer agents is a lot more tolerable than something like the NNRTIs or the protease inhibitors are. And then next we have our integrase inhibitors. This is an important class because nowadays a lot of the recommendations from the CDC or NIH is that these are going to be your kind of go-to drugs for the most part. So when we look at the cocktails in a few minutes here, we're going to find that these are going to be kind of your go-to drugs for the most part. So we have drugs like raltegravir, we have dolutegravir, and then elvitegravir. This one's actually one that's co-formulated with that cobicostat, that 3A4 inhibitor, to kind of boost levels up to decrease how often we have to give it. And then this is actually a new one I added for this year when I was checking out the regimens, called bictegravir. And so this one's actually in a combination with the emtricitabine and tenofovir. And again, we're going to look at combination therapy in a little bit, but these are two NRTIs that you're mixing this with, and it forms this drug called Biktarvy that we're going to be giving. This is actually going to be an important one from first-line drug regimen cases. But anyway, basically what this does is bind to that integrase and tries to prevent the viral DNA from ever being incorporated into our DNA. Okay, so again, you may be able to produce it with the reverse transcriptase, that DNA, but it never gets incorporated into our DNA. So again, this is going to be another one of those drugs that's kind of the main feature of one of these cocktails here. Again, very well tolerated, rash, nausea, headache, much better tolerated than a lot of the older drugs like the protease inhibitors and NNRTIs. So again, looking at drug interactions, some of these are on purpose. So for instance, ritonavir, by boosting 3A4 or by inhibiting 3A4 or boosting levels of the other antiretroviral drugs can be good. But some other things to consider, efavirenz, etravirine, and nevirapine can all actually induce 3A4. So it may cause levels of the other drugs to actually decrease, which can be problematic. Most protease inhibitors will have some 3A4 inhibition, so again, you want to be mindful of that. And this can be important though, because imagine what's one of those opportunistic infections these patients can develop. Tuberculosis, right? And what do we mention as the drugs we use for tuberculosis? We talked about this back in Palm, back in the day, but rifampin. Anyone remember what rifampin does? 3A4 inhibitor or inducer? It's an inducer, right? That was what made rifampin sort of unique there. So by inducing 3A4, it may actually drive down levels of your protease inhibitors, say that was the regimen they're on, and guess what? Now all of a sudden, maybe your viral load starts to go up, maybe your CD4 starts to go down, even though the patient says they're being adherent to their drugs. Well, it could be related to a drug interaction. Maybe the levels are not high enough to where they should be. These are things you have to consider, right? As far as food-drug interactions go, these need to be looked up on a case-by-case basis. In some cases, you may need an acidic environment to be absorbed, which means you'd want to do it on an empty stomach. Sometimes they're going to be aided by fatty foods, all these things. So you want to make sure you look it up. When in doubt, especially if you don't deal with these patients on a day-to-day basis, look it up. Because are you going to encounter these patients? Absolutely, it doesn't matter where you are, whether you're in the urgent care clinic or in the ER, family practice, ortho, derm, you're going to run into these patients, and so you need to be aware of what they're on, why they're on it, and what could happen if you start to mix and match your drugs that you commonly use with their drugs, right? Okay, so the treatment, as I mentioned, is an ever-evolving process. So if you're ever interested, look at the current guidelines. You go to aidsinfo.nih.gov. It's a very good website to go through, and it'll walk you through the whole process. Right? It's geared for both patients, the layperson, and also for healthcare providers to be like, well, what do I need to do for these patients? How should I treat their opportunistic infections? How should I get them started? They have post-exposure prophylaxis. How do I do that? What drug should I be using for this patient? So what we do know is that basically the regimen is going to be a minimum of 3 drugs. Okay, so first off, you need at least 3 drugs. The backbone of those 3 drugs are going to be 2 NRTIs. Now, it may seem counterintuitive because you're like, well, why would I use 2 drugs of the same mechanism? I don't know. This is the way they did the studies. That's what they found tends to be effective. But 2 NRTIs are going to be the backbone of your regimen. And then you're going to add on the 3rd drug, which could be a protease inhibitor, could be an integrase inhibitor, could be an NNRTI. Those are kind of the 3 big things you may find as the most common sort of drug regimens there. Nowadays, by the aidsinfo.nih.gov is recommending as first line, typically is going to be an integrase inhibitor with 2 NRTIs, which is why I kind of made note of those. Those are a newer class of drugs. They tend to have less side effects than like the protease inhibitors and NNRTIs did. So for instance, something like raltegravir plus tenofovir plus an emtricitabine, this is your integrase inhibitor. These are your 2 NRTIs, right? If you looked at a PI, sort of a protease inhibitor sort of regimen, you'd see darunavir that would be boosted by ritonavir, so that's 2 drugs, plus tenofovir and emtricitabine. Or if you did an NNRTI, you do efavirenz plus tenofovir plus emtricitabine. Okay, so again, just to show you, you want 2 NRTIs plus 1 of a different class, usually an integrase inhibitor, but could be a PI, could be an NNRTI. And then in some cases, you may add on something like a fusion inhibitor. In some cases, you may add on that CCR5 Antagonist. That's going to be much more on a case-by-case sort of basis here. But if you just had an otherwise healthy individual just come up and have a brand new diagnosis, one of these regimens is probably going to be pretty good for them from that standpoint. Okay. Now, adherence, do you think everyone's going to be super adherent to their HIV regimen? Not necessarily, right? And again, this is going to be a short course. They're on for 6 months and they're done. That was a lifetime illness, right? So until we come up with a vaccine or something like that for it, they're going to be stuck with this. So again, consider what their social economic status is, consider what they can pay for, consider what, you know, are they homeless, like they have any kind of social system support. These are all going to be really important things. In some cases, if they're not going to be adherent to a regimen, you might be better off just not even treating it in the first place. Because again, what's going to happen if they just take it sort of every once in a while? It's going to get resistant, right? And then if they pass it on to someone else, it could be more resistant for them. Right? These are things you have to consider, right? Other reasons for poor adherence, you know, psychiatric illness, substance abuse. Why do you think substance abuse would be a common comorbidity in these HIV patients? That's maybe how they got it in the first place, right? So if they're sharing used needles or something like that, that could be how they got spread to them in the first place, right? These communicable diseases. Adverse effects being another big thing. Oftentimes they're going to feel worse on the drugs than they are off of them. So that's why that could be a problem there. And then again, just unstable social circumstances. So again, if they don't have a consistent home to go back to, if they don't have access to transport or access to medical care, these are all things that can lead to poor adherence. So other things we can do to try to help enhance their success, use combination formulations whenever available. If you can get 2 or 3 drugs combined into one pill they have to take a day, fantastic. There's one of the new ones that had come out a couple of years ago. They kind of changed things around quite a bit. It was called a tripla. Actually had 3 drugs all together in the same pill. You should have 1 pill a day. That's a huge difference and huge impact on adherence compared to what it was, say, 10, 20 years ago. Again, look at things like food restrictions, you know, as far as, you know, what type of, you know, they take on an empty stomach or fatty foods, etc. And just to give you some examples of some combination drugs that are out there. Tripla, which is efavirenz plus emtricitabine tenofovir, emtricitabine plus rilpivirine plus tenofovir is Complera. So there's a lot of ones that are out there. And again, if you work with these patients on a consistent basis, you'll get pretty used to these. All right, so resistance testing. So there's 2 different types of resistance testing you can do for the virus itself. There's phenotypic testing and then genotypic testing. Anyone know what the difference is? Remember phenotypes and genotypes? Did we go back to the pea plants and do the Mendelian genetics and all that fun stuff? Right. So phenotypic testing, basically this is actually, this is pretty similar to if you were to do like a normal like disc diffusion test for like a bacterial sample, right? So again, if I were to say get a bronchoalveolar lavage, and I were to get if I were to culture out, say, Pseudomonas, and I did a disc diffusion test to see which antibiotics are resistant or intermediate or susceptible, that's kind of similar to the phenotypic testing. Basically, this is comparing it to the wild type virus, and determining what this IC50, or the ability to inhibit 50% of that viral replication there. This is very slow, much higher cost, right? However, this is the most accurate way to determine what kind of drug regimens are going to be super effective for that particular strain of virus that that patient has. Now, would I do this on a new diagnosis HIV patient? Not typically, right? So typically they're going to have, you know, wild type virus. Typically they're going to be, you know, much more likely to respond well to one of these initial sort of recommended drug regimens, right? Like bictegravir, emtricitabine, you know, tenofovir, something like that, right? So one of those are typically fine for them. In the meantime, though, what you're probably going to do for them is do a genotypic testing, which is much faster and easier to do. Basically, what this does is it looks for specific mutations in the virus, and based off those mutations, and there's a whole database that will run it through. It says, well, based on its mutations, it's probably resistant to this, intermediate to this, and susceptible to all of these. Okay. Now again, it's not actually looking at, it's not really doing it in the real world. It's more of an in vitro sort of testing. So it's not as good as phenotypic testing, but it's much more readily available. It's cheaper, faster. So a lot of times people get genotypic testing done at the initial diagnosis. They'll get started on one of those initial regimens, and then when the genotypic testing comes back, it says, hey, that drug probably not going to work. We're going to switch you over to this instead. So that's kind of the general way you'd find out the resistance patterns. What you want to do for HIV in pregnancy is typically you treat them as a non-pregnant patient, because again, you want to make sure that you have to treat the mom, otherwise the mom's not around. Baby's probably not going to be around either, right? And so the idea here is you want to maximize that viral suppression as best you can. So the lower the viral load is in the mom, the less likely they are to spread it over to the baby. So, and again, I think I put one of these in your prescription assignment. Did I? Like to a neonate or something, administering HIV meds to. I believe it's one of the right. You should probably check out your prescription assignment at some point. Yeah, so for instance, but there are some drugs you would want to avoid. So for instance, efavirenz can cause neural tube defects. Remember any other drugs we talked about that can do that? Proic acid can actually do that too, yep. And so typically what we'll also do as well in the intrapartum period, prevent transmission, we'll do zidovudine just as a single agent. So for instance, we will give fetuses zidovudine for 4 to 6 weeks. That way any virus they may have picked up from mom, say from the birth canal or from the bloodstream, it'll suppress that viral replication, and usually for the most part pretty successful in preventing them from getting it in the first place, which is nice. And then typically avoid breastfeeding. That avoids drug exposure, possible viral exposure to the baby. Now, chemoprophylaxis, what does that mean, do you think? Prophylaxis just means preventing it before it happens, and then chemo just means giving you drugs for it, right? So it basically means giving you drugs to make sure that high-risk workers are not at increased risk for developing the infection, or maybe after an exposure has occurred, how do you prevent the actual disease from taking place, essentially? This is important for healthcare workers, because guess what? You may be in the trenches there dealing with patients. You're sewing up a laceration for a patient who has HIV, right? I remember my first rotation I had was in a Coumadin clinic, and I had this patient who was this older dude, and he had HIV, Hep C, and I was actually the one doing the finger stick to get the INR. It's like a point of care testing thing. And I mean, like, this guy had like the most callous fingers I'd ever seen in my entire life. I'm just in there trying to milk this blood. I'm like, please don't get my, you know, super low risk. But you may be doing more of high risk sort of things there where you want to be really cognizant of this. So again, always, it's nice if you know the HIV status of the patient, but do you know the status of your patient definitively? Probably 99% of patients you deal with? Probably not, right? So if not, you want to go with the worst case scenario, which is they had the disease until you know otherwise. So if you can get a blood sample from the patient, that's always going to be beneficial. But if you're working a busy ER, they may have gone out the door hours ago, and you don't know where they are anymore, right? So things to consider. If you do have a really high risk sort of exposure there, you definitely want to start therapy as early as possible. And typically they're going to start off with something like a full court press, basically where you get raltegravir, which is that integrase inhibitor, plus emtricitabine and tenofovir. So that way you get 2 NRTIs, you get an integrase inhibitor, you do that for 4 weeks. So just in case any virus did enter your bloodstream, it's going to be inhibited from replicating, from integrating into your DNA, and then you prevent the infection from ever taking hold, right? That's called post-exposure prophylaxis there. In some cases, you may have pre-exposure prophylaxis. So for instance, if you were at risk if you're engaging maybe high-risk activities, so maybe if you have partners with discordant status where one has HIV and one doesn't, that could be a case where by doing something like daily tenofovir emtricitabine, that can help to prevent transmission, right? So something to consider there, especially IV drug abusers, but again, you want to make sure patients are seronegative prior to starting the prophylaxis, because otherwise they have the disease and they need to be treated just like anyone else that has the disease there, right? So something to consider. And then looking at the outcomes here, obviously you want to look at their baseline CD4 and see how that's going to be changing as time goes on, and look at their HIV RNA load. Again, that should be undetectable. And typically you're going to do that genotypic testing right off the bat as well once you make the diagnosis. Then you're going to be monitoring drug therapy every 3 months to make sure the load becomes undetectable. And at that point, they are in more of kind of a maintenance sort of phase there. Now, reasons why you might want to change drugs. One would be if they have intolerable side effects, so they just can't tolerate it, or they develop, transaminitis or something like that. Or if they have a treatment failure, so after 3 months or so, they still have viral RNA copies greater than 200, that would be considered a failure. Or if they have documented resistance. So the genotypic testing comes back and says, hey, raltegravir is not a good drug for this patient, switch them over to something else. And that way you get a new regimen, hopefully get undetectable. Now, I only have a couple minutes. I think, how many more slides is this? Let me know. Look. How many? A lot? Looks like a lot? You would say that, wouldn't you? Okay, let me check the sticky board, and then I got about 5 minutes left, so I'll check the sticky board. You guys have any questions before I stop the recording? It's a lot of drugs, but again, just repetition is going to be the biggest thing to try to help you recognize, okay, this fits into the NNRTI category. What do I know about NNRTIs? This fits into the PI category. What do I know about PIs, right? Et cetera. So those are things you want to key in on.